Hello and welcome to MD Newsline. Thank you so much for joining us. Can you please introduce yourself to our audience?
Yes, I'm Karine Tawagi. I'm a genitourinary medical oncologist here in Chicago at the University of Illinois in Chicago. So I specialize in treating patients with bladder cancer, kidney cancer, prostate cancer, and testicular cancer.
So ASCO was probably the best place for you to be this week.
Yes, it was a really exciting time. We had a couple research studies that were presented in all of those areas that I'm excited to delve in more about today.
So let's start off with bladder cancer. Talk to me a little bit about what your experience has been like and some of your challenges in treating bladder cancer and what you found at ASCO that was applicable to your work.
Absolutely. So, when we're thinking about bladder cancer, we think about patients that have localized disease, where the higher risk patients have disease that extends into the muscle part of the bladder, thinking about the bladder as having multiple layers, the muscle being that middle layer. And we know that those patients are at higher risk of having recurrent bladder cancer when their bladder is taken out with a surgery called cystectomy. So, when we're thinking about ways to improve the outcomes for those patients, we think about giving chemotherapy before the surgery. One of the issues is that the only chemotherapy approved is for patients that are cisplatin-eligible, meaning that they have a good renal function, no hearing loss, no significant neuropathy, a good performance status. And in the last 6 months or so, we've had the FDA approval of a new treatment, a new standard of care in this area for cisplatin-eligible patients with muscle-invasive bladder cancer. And that is the Niagara study, which is looking at our traditional platinum-based chemotherapy with gemcitabine cisplatin, but adding an immunotherapy component called durvalumab, both in the neoadjuvant setting and then for cycles in the adjuvant setting as well, with durvalumab by itself. One of the other challenges is that we do not have a good regimen for cisplatin-ineligible patients in the neoadjuvant setting. There are trials ongoing looking at whether we could give treatments that could improve different endpoints for patients that are cisplatin-ineligible. But this is a really interesting space. And then there's a lot of interest as well as far as bladder preservation, because I face patients frequently that do not want to have the surgery to remove their bladder for significant quality of life reasons. And I think a lot of this space is moving to biomarkers to predict which patients will do well with systemic therapy alone. How can we move towards more of a bladder preservation? So there were two interesting studies that I'm thinking of that were presented at ASCO this past weekend with regards to bladder preservation and with regards to using CTDNA with that regimen of gemcitabine, cisplatin, and durvalumab.
Mhm. So, talk to me a little about the study specifically on bladder preservation. What are some of the complications that come with maybe not being able to preserve the bladder, and how often do you run into just simply not being able to preserve the bladder? Like, what's the level of quality of life impact?
So the quality of life impact as far as having a cystectomy includes sexual dysfunction, bowel and bladder dysfunction. Patients either end up with a neobladder where they have to self-catheterize, or they end up with a urostomy where they have, an external bag where they drain the urine. So there are significant also mental, emotional tolls that come with these long-term side effects. So one of the trials that was presented at ASCO, the SURE-02 trial, was looking at patients that got sacituzumab govitecan, which is an antibody drug conjugate that binds to TROP2 with pembrolizumab in the neoadjuvant setting. And so the rate for clinical complete response for the patients on this SURE-02 trial was 44%. So this is interesting, phase 2 trial looking at, can we offer patients the possibility of preserving their bladder? As it stands now, we have the option of chemotherapy with radiation for patients that choose to preserve their bladder if they meet certain metrics, such as not having too large of a tumor, not having multiple tumors, not having significant bladder dysfunction, or having hydronephrosis where the kidneys are enlarged as a result of blockage. But right now, we know that there's really good efficacy as far as neoadjuvant systemic therapy followed by cystectomy. And that was another of the big abstracts that was presented at ASCO. And the update at ASCO this year was the use of ctDNA to tell us a little bit more from a prognostic standpoint how ctDNA fits into this regimen.
You talked a little bit about the comparison of some of these regimens to what you would normally do. Are there any main areas where you're like, this is a major improvement, or areas in old regimens that you're like, okay, this was a little bit better, this is an area that we might want to preserve? And is there any room to maybe combine some of these regimens at all?
Absolutely. So We saw with the addition of durvalumab to our traditional platinum-based chemotherapy a significant improvement as far as event-free survival and overall survival. So that is our new standard of care as far as patients that are cisplatin-eligible with muscle-invasive bladder cancer. Some of the data that was presented at ASCO this past weekend looked at CTDNA and found that, and that's circulating tumor DNA from a blood sample, and found that patients that had that at the beginning of before they started any of their treatment, 57% of those patients were positive. And for patients that added that immunotherapy durvalumab to the original chemotherapy that we had, 13% increase of the ctDNA clearance for patients that added the immunotherapy. So we know that immunotherapy is improving the ctDNA clearance. At this point, ctDNA is prognostic, not predictive. So it doesn't change anything as far as the duration of the regimen, but we do know that patients that don't clear their ctDNA do worse. And so in the trial, they looked at ctDNA after surgery, cystectomy as well. And we know that those patients don't do as well. So I think where the future is moving to is, to your point, combining different approaches. So there are trials looking at for patients that are ctDNA positive, meaning we know that they're going to have a more aggressive disease. Can we intensify their regimen and have a more personalized approach? For patients that are ctDNA negative, maybe those patients don't need the full duration of adjuvant treatment. And so there are trials, one called the Modern trial, which is looking at this question of escalation and de-escalation based on the ctDNA response. And then to your point too, as far as combining these approaches, there's also a trial that's going to be looking at giving chemotherapy followed by chemotherapy with radiation to look at more options for bladder preservation. And we've seen a few trials in the last few years where patients get either systemic therapy alone with or without radiation. And we're looking at the rate of clinical complete response with the option of bladder preservation. And I think that, moving into the future, hopefully we'll get to a point where patients can keep their bladders, not have to go through cystectomies, and still have long-term durable responses.
Just on the bladder preservation a little bit, do you think that the Niagara's adjuvant component could be adapted for non-surgical candidates using ctDNA dynamics to guide treatment, duration, or intensification?
I think it's possible that we could be thinking about, can we offer bladder preservation to some of the patients that are on a similar regimen based on metrics in the clinical CR definition of having a repeat TURBT or transurethral resection of the bladder tumor that is negative, of having an MRI with no evidence of disease, of having a negative ctDNA. For those patients, could we consider offering them the option of bladder preservation? There was another phase 2 trial maybe 2 years ago that also looked at chemotherapy with immunotherapy and did offer patients the option of bladder preservation. And it was nivolumab in this setting rather than durvalumab, which was studied in Niagara. So I absolutely think that we should be thinking about those questions as we're designing trials moving forward.
How do you think cost, access barriers to ctDNA monitoring and immunotherapy impact maybe equitable adoption of things like, the Niagara protocol?
That's a great point. So I think, we, where I work, are very passionate about healthcare equity and making sure that we absolutely offer the standard of care to all patients. And as of right now, we have a way to check some of these assays free of charge to the patients, but is that going to be a sustainable model? I think that that's a great question as far as making sure that as these novel therapies and tests are approved and maybe standardized and part of the guidelines, which they are not at this time, that it is an equitable thing for all patients.
Do you have any thoughts on what defines success in bladder preservation? Do you think like ctDNA negativity and clinical, excuse me, let's just go with, do you have any thoughts on what defines success when it comes to bladder preservation when you look at patients?
I think that success would look like long-term recurrence-free survival of their cancer, and that there was still no detriment as far as their overall survival. So although we want to improve some of these quality of life metrics, not at the cost of having patients live long and well.
Let me see. Is there anything else on this study specifically that you want to cover when it comes to bladder preservation, ctDNA, anything that we haven't covered yet?
think that pretty much covers some of those issues. Let me think.
This is good. Okay. All right. So we were at. Now we're gonna go to prostate cancer. Sound good? Okay. So tell me a little bit about what your experience has been treating patients with prostate
Oh, can I
cancer.
say one more thing on
Yeah,
bladder
please go
cancer?
ahead.
Yeah. Okay. So I think on the issue of CTDNA and bladder cancer, it would be really interesting to think about it in the metastatic setting as well. So as of 2 years ago, we have our new frontline standard of care, enfortumab vedotin, which is an antibody drug conjugate against Nectin-4, combined with pembrolizumab, and that surpassed both progression-free survival and overall survival compared to platinum-based chemotherapy. And we know, and this was one of the points that was brought up during the discussion this past weekend, is that patients can have a lot of toxicity from long-term enfortumab vedotin. It is a chemotherapy payload, and patients can have significant neuropathy. They can have skin toxicity as well as others. And so thinking about integrating ctDNA in the metastatic setting with their new frontline standard of care, I think is also really important, because could we figure out a way to pull off that enfortumab with the use of ctDNA? Could we be thinking about ways to be proactive rather than reactive when it comes to the neuropathy that happens as a result of long-term enfortumab? We know that the responses are excellent, but we don't want long-term toxicities to accompany those excellent results. And so I think there was a retrospective poster presented at ASCO that looked at ctDNA in patients with metastatic urothelial carcinoma, and I think over 90% had positive ctDNA. It was a small study of 30-something patients, but I think the future of thinking about escalation and de-escalation across settings in bladder cancer will involve ctDNA.
Mhm. If you were to think of what safeguards might be useful when it comes to de-escalating, do you have any thoughts on what could work?
I think, patients that clear their ctDNA have good responses on imaging. Those are things that we could be thinking about. Could we either reduce the dose of enfortumab? Could we be thinking about switching to a different regimen to prolong that sustained response? We had results talking about the durable response that patients that respond have. So patients that have a clinical, sorry, I'm going to repeat that. So we had an update from EV302 this past weekend on a subgroup analysis of patients that had a complete response, and 75% of those patients still were in CR at 2 years. And then for patients that had any response, about half still had a response at 2 years. So we know that patients have durable responses, but could we be thinking about different agents to switch out? Could we be thinking about different agents to switch out the enfortumab as far as keeping that durable response? Could we be thinking about different agents that wouldn't cause neuropathy? Or could we just drop the enfortumab and keep the immunotherapy on?
Hmm. When it comes to talking to patients about these potential pitfalls, we talked a little about toxicity, neuropathy, and potentially new therapies. I mean, we're probably a while from getting approved for a applicability. I mean, FDA approval. I feel like I hear that a lot. There's a lot of promising things on the horizon. How do you talk to patients about complications, and then maybe cover a little bit about how you talk to patients about things like clinical trials?
Absolutely. So I think, whenever we think about starting these regimens, and in the case of enfortumab and pembrolizumab, it is the standard of care for patients that are cisplatin eligible or ineligible. We do talk about that, half of patients can have neuropathy, half of patients can have skin toxicity. There's a rare toxicity of ocular toxicity, high blood sugars, things like that are important for us to counsel patients so that they can tell us when they have any onset of these side effects so that we can manage them appropriately. So there are a lot of supportive medicines that we can give to make those side effects better. And we can also reduce the dose of the treatment as well to make those side effects better. I think as far as clinical trials, this is really important that patients, have equitable access to clinical trials. And so I think we talk to patients and, say, you're going to have either the standard of care or something better in the case of a phase 3 trial. Can we be thinking about, the next phase of improving the outcomes for your disease? a patient like you can, now do much better with the treatment that they're, sorry, I'm going to start that again. We talk about how a patient, I might tell my patient, a patient just like you, sorry, let me think of how to phrase that. So, I think really the only way to advance the outcomes is to enroll patients in clinical trials and to keep doing research that is meaningful to our patients. So I think having trials where we believe in both the control arm and the intervention arm and counseling patients and offering those trials and making sure that they have equitable access to these trials is really, really important. So, we have a wide variety of trials where I work, and whenever we have a patient that could be eligible for a potential trial, we discuss it, and we have to eliminate some of the misconceptions around clinical trials or the fears around clinical trials and educate patients on, the benefits of trials and how this is the future in terms of improving outcomes for patients with this disease.
Yeah. So let's talk a little bit about prostate cancer. Tell me about what your experience has been working with prostate cancer patients and what you found at ASCO on this topic.
Absolutely. So we see a lot of patients with prostate cancer here at UIC, and we know that for patients that have homologous recombination repair mismatch deficiencies, we know that those patients can benefit from PARP inhibitors. So as far as prostate cancer, we know that patients with homologous recombination repair deficiency mutations respond well to PARP inhibitors. And so those are approved in the metastatic castrate-resistant prostate cancer. So the point where the prostate cancer is no longer responding to our hormone therapies, that is the setting in which it's approved. We had really interesting data presented at ASCO looking at this in an earlier setting, so in the castrate-sensitive setting. So in the setting where the cancer is still responsive to the hormone agents that we use. And so this trial looked at niraparib, which is a PARP inhibitor, with abiraterone. The trial is called the Amplitude trial. And it was looking at, should we be moving those drugs up into an earlier setting? It did meet its radiographic progression-free survival endpoint. But I think one of the main questions is that for patients on the control arm that could potentially benefit from these drugs, only 36% of patients eventually got those drugs because it was an international study. So I think that begs the question of sequencing. Will patients do better if they get these drugs sooner, or will the survival be the same if they still have access to those drugs at the time of progression? So I think that's a really important question because these drugs do come with long-term side effects, including a very small but serious risk of blood cancer disorders such as myelodysplastic syndrome and acute myeloid leukemia. So I think it's important to have more data on overall survival, and it would be great to see more data where patients could all in the control arm get access to these drugs to know the true benefit of moving them earlier in this setting. So I think as far as where I stand in clinic today, PARP inhibitors are still only approved in the castrate-resistant setting. We know that these HRR mutations, there are some patients that do better, so they do not all respond equally. So the BRCA1 and 2 are the ones that have the most efficacious data as far as PARP inhibitors. And so if I have a patient with one of those mutations, I absolutely counsel them on the benefit of PARP inhibitors. The main question remains sequencing. Is it better to give chemotherapy first, or we have newer radioligand therapies like Pluvicto or the PARP inhibitors? And there are a lot of other mutations that were included in those trials, things like ATM, CDK12, CHEK2, FANCA. There are other mutations that don't respond as well, although the approval is there for those mutations as well. So I think it's important to pay attention to the type of mutation, think about what options we have, think about priorities for the patients. This is an oral agent, which is a benefit. And I'm excited to hear more about this Amplitude trial as some of the data matures and we see more about the overall survival as well.
Yeah, just in regards to your comment about the different mutations, do you think that PARP inhibitor and androgen receptor pathway combinations are going to be useful at all when it comes to this, or do you think that there's some that are just going to be more effective with certain mutations? Do you have any thoughts on combining?
So we definitely know that there is synergy with the hormone agent and PARP inhibitors. We have 3 approvals of the combination also in the castrate-resistant setting. The issue is that patients on those trials did not receive a second-generation anti-androgen prior to receiving the PARP inhibitor. So we don't know the true benefit of, the combination versus if they were given in sequence. But I think that that is a great point about the combination. And, in this amplitude trial, it was given with abiraterone. So, and the control arm had abiraterone. So we know that the patients benefited with the addition of the PARP inhibitor in this setting. But the question of sequencing still remains because a lot of the patients on the control arm did not have access to the PARP inhibitor at the time of progression.
Mm. Um, you talked a little bit about what you were excited to see. What direction do you hope to see some of this research take in the future?
Well, I think the first step is on a level in the community and academics. It's important for all patients to get germline testing and somatic testing to know if they have any of these mutations. So that's the first step. I think as far as moving this research forward, it would be great to have more data on the overall survival in terms of getting the approval in the earlier setting. So I think until we see those results, it may be challenging to think about moving this drug in the earlier setting.
So let's talk a little bit about kidney cancer, which there was another exciting study that you saw at ASCO in regards to that. So tell me about what your experience has been and what some of your challenges have been with working with kidney cancer patients.
So, as far as kidney cancer, we know that we have the approval of adjuvant immunotherapy for 1 year for patients with resected localized kidney cancer or renal cell carcinoma that has high risk features based on the Keynote 564 trial, which gives patients adjuvant immunotherapy, pembrolizumab, for 1 year after their nephrectomy or their surgery to remove the kidney. And we had an update from that trial this past weekend at ASCO talking about the 5 year update of the data. So it continues to show a significant disease-free survival benefit and a significant overall survival benefit. I think one of the important things, there was a really interesting case-based management discussion this past weekend that talked about counseling patients on the risk benefit of the adjuvant immunotherapies. So there are different risk calculators. One that I use is called Assure, where you can plug in different features about the tumor size, the histologic features, the grade, and it can tell you what the risk of recurrence is for that patient specifically. So I think that can help as far as knowing the risk for each individual person and when counseling the true benefit of the adjuvant immunotherapy. So we know that patients with more advanced, bigger tumors, higher grade, maybe could benefit from the immunotherapy more than those patients on the trial that had smaller tumors. That being said, I have the discussion because across the subgroups there is a benefit. So I think it's really important that those patients get referred from urology to medical oncology to have the discussion on the benefit of the adjuvant immunotherapy, particularly if they have also features that are more aggressive, like sarcomatoid features and things like that.
Yeah. Let's talk a little bit about multidisciplinary work. What has been your experience where we kind of go back to the study? What's been your experience in working across specialties with patients in general for all of these cancers that we've mentioned? And where are some of the gaps that you've noticed, or what would you like to see happen in the future?
I think a multidisciplinary approach is absolutely essential in 2025 across tumor sites because our treatments are becoming so complex. A lot of times, the regimens don't follow the guidelines exactly, or the case scenarios don't follow the guidelines exactly. So I think it's really important that we have a multidisciplinary approach, particularly if there are features like variant histology, so not the traditional histology that's seen for each of these tumor types, talking about educating our colleagues that maybe are not at ASCO attending these meetings and getting the updates on these systemic therapies. So, talking to our urology colleagues and making sure that they know the updates on some of these drugs. I think we are in most centers, there is a very good multidisciplinary approach between, at least in genitourinary oncology, between our urology colleagues, our radiation oncology colleagues, pathology, radiology, nuclear medicine. And it's absolutely essential that that all teams are educated on the updates that are occurring with all of these trials. And, if there's a case, for example, the case management um, So, for example, the case-based discussion that happened in RCC this past weekend was looking at, a multidisciplinary discussion. And to the point of localized kidney cancer and adjuvant treatment, there was also a discussion about in the metastatic kidney cancer setting, the role of cytoreductive nephrectomy. And we know that at this point, there is not good evidence for cytoreductive nephrectomy across the board, but it can be considered in select cases, either patients with minimal tumor burden, oligometastatic disease, or if they're highly symptomatic, but otherwise systemic therapy is the best approach upfront. But even for those cases where it could be considered, I think it's really important to have that discussion with urology to discuss the role of nephrectomy, to have the discussion with radiation, to discuss the role of radiation to the primary. There are a lot of trials in this space looking at the true benefit of that. But I think that multidisciplinary approaches are absolutely essential. In bladder cancer, for most of the muscle invasive bladder cancer cases, we want the patient to see the urologist, the radiation oncologist, and the medical oncologist to talk about the option of bladder preservation and to talk about the option of cystectomy and with or without neoadjuvant chemotherapy.
Well, thank you so much for joining us on MD Newsline. It's been an absolute pleasure.